So today's topic is ESBL trap. It is story between Piptas versus Meropenem, and what you must know. Or in other words, if a patient is infected by ESBL pathogen and culture reports show Piptas sensitive, as we usually see, and we put patient on this Piptas and patient dies. So what is this story? Why this happens? First, you should know that as per Embler's classification, there are 4 subgroups or classes: class A, class B, C and D. Then within this class A, there are 3 groups. One is penicillinase, another is ESBL, penicillinase is ESBL, and then are carbapenems. These penicillinases are the primitive enzymes, and they catalyze penicillins like ampicillin, amoxicillin, piptase, whereas more mutated form of these enzymes are ESBL. They break down penicillins in addition to that of third generation cephalosporinus plus aztreonam. Now comes this carbapenemases. They hydrolyze penicillins plus third generation cephalosporinus plus aztreonam, but in addition to that, carbapenems. Now what happens if a patient has UTI? There are 2 patients, for instance. One is patient having simple UTI, uncomplicated. Another is having for example UTI with bacteremia, and organism in blood is the same organism causing this UTI, for example complicated UTI, and lab reports have shown that in the both instances ceftriaxone is resistant and piptase is sensitive, Mero is sensitive. So how will you treat these 2 conditions? There was this non-inferiority RCT, randomized control trial, that took place, and 391 patients were included. They had E. coli, Klebsiella, bloodstream infections, and they had the same report: resistance to ceftriaxone, that is third generation cephalosporins, but susceptible to piptase and Mero, and 30-day mortality. So when we saw 30-day mortality, it was with piptase it was 12.3, whereas with Mero it was 3.7. So even if it was sensitive to Piperacillin Tazobactam, then why did this mortality increased in this group compared to Meropenem group? That is the paradox that we need to understand. So what ESBLs actually hydrolyze? The true spectrum is the one first is penicillins, that is ampicillin, amoxicillin, piperacillin. So piperacillin is also hydrolyzed by, so this is also hydrolyzed by this ESBL pathogen, and also true under true spectrum, one is penicillin, another comes third generation cephalosporin, then comes monobactam, and carbapenems is not hydrolyzed by ESBL pathogen. So yes, biochemically an ESBL should make the bug resistant to piperacillin too. So if this bug is resistant to ceftriaxone, so you will suspect, for instance, ESBL, but you will get confused that why is this Piperacillin Tazobactam sensitive to ESBL. So in the first place, this is wrong then, because if it is ESBL, it should have been ESBL pathogen. It should hydrolyze penicillins, that is piperacillins. So this should have come out to be resistant, but here in the susceptibility reports it is sensitive. So will you consider this bug here, which has shown spectrum, that is ceftriaxone resistant, piperacillin sensitive, Meropenem sensitive? Will you treat this as ESBL pathogen or not? So the answer is you have to treat it as ESBL pathogen. I'll explain the reason. So our question is, why Piperacillin Tazobactam, that is PTZ, may still test sensitive in ESBL? This is the part that causes the confusion. You see, Tazobactam, what happens? Tazobactam inhibits most class A ESBL enzymes in vitro. So this Tazobactam is the reason that is causing the confusion. So when the lab reports test piperacillin, what lab tests? It tests piperacillin plus tazobactam. It doesn't test piperacillin alone. So many ESBL producers will appear susceptible in the report, but that susceptibility is an in vitro phenomenon under standard lab conditions, not necessarily reliable in severe infection. That's exactly why the non-inferior trial that was done showed sensitive piperacillin tazobactam in an ESBL. So in most Enterobacteriaceae, high level resistance to third generation cephalosporins, especially ceftriaxone, almost always due to an ESBL or AMPC. AMPC producers, although they are rarer in E. coli, Klebsiella than ESBL producers. So this ESBL producers, and so AMPC, the producers are rarer in E. coli and Klebsiella than ESBL producers. So ceftriaxone resistance in this species is ceftriaxone resistance in this species is ESBL until proven otherwise. So if lab workflows is you screen ESBL pathogen and you screen, for instance, E. coli, and this ceftriaxone minimum inhibitory concentration comes out to be greater than 2 microgram per ml. So this is a possible ESBL. So how will you confirm ESBL pathogen? By phenotypic testing, for example, synergy with clavulinate or genotype PCR. So for instance, if it was resistant to ceftriaxone, but when you added this for instance or clavulinate, it became sensitive. That's how you confirm ESBL pathogen. So for instance, patient had E. coli or Klebsiella resistant to ceftriaxone. Statistically, in these species, this pattern is most often ESBL. So PTZ, that's piperacillin tazobactam susceptible result, came from tazobactam masking the ESBL activity. It was tazobactam that was masking the ESBL activity in vitro. That's why test came susceptible. So trial tested if that S translates into the real world for bloodstream infection. It didn't. That's why carbapenem is still better and decrease the mortality. So when you use piptaz here, so although it was sensitive as per the reports, but it didn't translate into the this real world scenario, because although this is sensitive, it is because of this tazobactam, but piperacillin as such is having no action against this ESBL pathogen. That's why it increased mortality. compared to the Meropenem group. So the important clinical distinction is ceftriaxone resistance in E. coli or Klebsiella, think ESBL first. Piperacillin Tazobactam sensitive in such isolates does not mean you can trust it for bacteremia. So in other words, if a patient has, as I have given two case scenarios, one was simple UTI, another was UTI with bacteremia or complicated UTI. So if a patient comes with cystitis or mild UTI, even if it is ESBL pathogen, but and PIPTA shows sensitive spectrum. So because there is no bacteremia, we can still use PTZ as drug of choice. But here, if bacteremia is present, for example, a patient with urosepsis that has bacteremia, so in such a case, even if PTZ is sensitive and you found ceftriaxone resistant, that means you are playing with ESBL pathogen here. So it has been seen in a patient with ESBL as the bug plus bacteremia. In this instance, if ceftriaxone is resistant and PTZ is sensitive, don't use PTZ. So don't use. So caution is to be exercised here. Don't use PTZ here. Use Meropenem instead. So that was the answer why Piperacillin Tazobactam fails in ESBL infection even when the lab says susceptible. So that is why this is the ESBL trap. That's why what you must know about this Piperacillin Tazobactam versus Meropenem. So ceftriaxone resistance, think ESBL. Don't fall for the PTZ susceptible report. So when lab says S, it means you use PTZ and patient has bacteremia, patient will die. You have to upgrade antibiotics to Meropenem. So that's why this susceptibility report, it lies. That's why you have to understand ESBL and antibiotic choices.